Hi, I'm Dr. Peterson. We're going to talk a little bit about documentation, why it's important, some tips, and just some of the philosophy from a medical director's standpoint about why patient care documentation, good patient care documentation, is important. I think this is something that maybe doesn't get emphasized enough in EMS. There's a number of reasons why documentation is important, and we'll get to that. And I'm going to reference several online articles that I'll post the links to at the end, a couple from the website ems1.com, as well as from a blogger named Chris Kaiser, who's the author of lifeunderthelights.com. So I think the first thing let's talk about is why are we writing documentation? Who is the audience that we are writing to when we write a patient care report? I see it as four main audiences that we're writing this for. Each one of them is important, but each one of them serves a different purpose and may have some different reasons for why you do what you do or don't do what you don't do. The first is communication with other healthcare providers. That is the most urgent responsibility or purpose for your patient care documentation, especially after you hand off the patient to the emergency department, and now the nurses, physicians, and then as the patient gets admitted, the inpatient team is sometimes and often relies on your documentation to provide key pieces of information about the patient. A lot of times it's social status, condition you found them in, your assessment, your interventions, things you do may actually improve their situation so much that it's not obvious to the hospital side what the patient, what situation they were actually in before you treated them. And the only way we would get that information is from your documentation. So communication with other healthcare providers, that's a very important piece of information for the imminent safety and ongoing decision-making for patient care for that patient. Another purpose is for billing. Maybe this isn't important to you, but I'm sure if you talk to someone in your agency, there is somebody who cares about your documentation from a billing standpoint. I believe for most of our agencies, most of you, billing is done by a third party, so it's a little bit removed from your day-to-day operations. Currently, we look to the government to provide guidance on documentation for billing. Even though a fair amount of the patients you transport have private insurance, Blue Cross, Health Partners, Aetna, all of those big payers, there's a fair number that have Medicare, and Medicare, as driven by the government, sets a lot of the standards that the commercial payers, the private insurance companies, follow. So even though we don't really have a government-controlled healthcare system, we kind of do, in a sense, have a government-controlled healthcare system. Medicare requires documentation of what they call medical necessity for an EMS transport. And this generates a specific billing level, whether it's BLS, ALS1, ALS2, and a lot of it just depends on how many medications you give, how many procedures you perform, and then of course the mileage that you transport the patient to the hospital. Right now, it's actually fairly minimal. You do have to justify what you're doing. However, going forward, there is imminent legislation and things on the horizon that we'll talk about in a little bit that may actually require more documentation on your end in order to get appropriately paid for the work that you're doing, or for your agency to get paid for the work that you're doing. The third reason for documentation is for quality assurance purposes. From a medical direction standpoint, this is critical because the only way we know what's happening within all of the agencies under our medical direction is through documentation. You can tell me all you want, but we got to prove it, and the only way we can prove it is through documentation. So you can tell me you're giving aspirin, you can tell me you're checking end-tidal CO2, but unless I see it in your chart, I can't prove one way or another that it's happening. So quality assurance, there's a lot of people that read your charts, more so than you realize. You submit that PCR report, there's people at your agency that are reviewing it for quality assurance purposes. In some agencies, it's even your peers. There's clinical supervision staff here at Regions EMS that review charts on a regular basis. Medical directors, we review charts on a regular basis. Obviously, your billers, your billing company has to review your chart to pull out some of those medical necessity pieces for billing. Hospitals review your charts. all of these serve a purpose, so just be aware that there's a number of sets of eyes reviewing your documentation, some for quality assurance, some for other purposes, but from a quality assurance standpoint, we have to have it documented in order for us to measure the quality of the care that you're providing. And we care about things that matter, not just reports and graphs so that we can show reports and graphs to people and feel good about ourselves, but we want things that matter, that change outcomes for patients, that improve outcomes, that make a difference. Things like giving aspirin for chest pain. Until we have blood tests that prove this patient is not having a heart attack, the single most timely, effective intervention you can do is give aspirin. If the patient had already taken aspirin, or maybe the dispatcher advised them to take aspirin, that's fine. It needs to be documented that the patient took aspirin prior to your arrival so that we can still understand that you are addressing the use of aspirin in chest pain. So there's a number of reasons for quality assurance. And then the fourth one, and not with the intent to scare you, but is legal defensibility. So 3 years from now, when you get called to court to testify for the care that you provided for patient X back in 2012, you're not going to remember that run. And what they're going to do is hand you your documentation, and that's going to refresh your memory, and they're going to hold you to everything that you wrote or didn't write. And if you make something up, that's how they're going to frame it, is that you're just making that up because it's not documented. So there is a role for your documentation to be used in your own defense and in legal proceedings should anything come up in the future. And a lot of times we don't know if or when that's going to happen for a given call. It may not seem like much, but then after the fact, more information becomes available. There was domestic abuse. It was actually an assault. There was something else going on. Maybe it was a workman's comp claim for a medical issue that was caused by something they were exposed to decades ago and now is coming to light. And there's no way for you to know that in the middle of any given run when it seems like just a standard headache or nausea, vomiting call. So let's get into a couple articles that I found that I feel like do a really good job of addressing some of these issues and purposes for our documentation. Like I said, I'll post the links at the end so you can review these as well. But the first one is from EMS 1. This is from 2015, and it's the title is "Why Documentation is Part of Good Patient Care." I mean, you can't say it better than that. So the summary points for this is we don't necessarily think about documentation as part of patient care. It is. And we need to understand that in order to change the culture of how we feel about documentation. Documentation, I would say, is an integral part of patient care. Like I mentioned before, when you hand off your patient at a hospital to the receiving staff, there are decisions that will be made based on your documentation immediately, in the next few hours, in the next few days. At discharge, can we safely send that patient home, or do we need to send them to some other level of care, whether it be a TCU or actually a nursing facility, a skilled nursing facility? And some of that's going to depend on your documentation of the conditions you found the patient in, what condition they were in before you treated them. A lot of things like sepsis, we need to know how much IV fluid you gave and your assessment. What were your vital signs? Those matter for the treatments that we're going to provide. Trauma, what was the mechanism of injury? A good description, verbal description of what actually happened so that we better understand the situation and we know what to look for and what things to watch for. So again, decisions made after handoff may be based on your documentation. So it's important to document thoroughly and timely so that we can get that report and make decisions based on your information. You are the eyes and ears in the field for a lot of the healthcare team in the hospital. We don't get the advantage of visiting somebody in their home like you do and seeing the situations that they live in and understanding some of the barriers to optimal health that those patients might have. And we're going to look to your documentation to find that. Like we mentioned before, health insurance may make payment decisions based on the presence or lack of documentation of specific interventions or circumstances that you find, which could leave the patient or the healthcare system with unnecessary expense. Imagine now that your documentation is not adequate enough to justify medical necessity from a Medicare standpoint. Medicare refuses to pay the bill. That bill may now go back to the patient for payment, all because you didn't document adequately enough to support the need for the care that you provided. Or maybe the hospital will get stuck with something because you didn't document that aspirin that the patient took prior to arrival. It gets to the hospital, there's some assumptions made, a verbal report that you gave, and then your report comes through later and it's not in there, and now there's no documentation, confirmatory documentation that that patient took aspirin. That could have easily been prevented by just an extra line of documentation in your chart. The article goes on to explain that the subtitle here is all share in the blame for poor documentation. It's not individual medics necessarily. It's actually a culture in EMS. I feel like other disciplines within healthcare, the physician side, the nursing side, the hospital-based, the clinic-based, there's a culture that you have to document everything. And our mantra is if you didn't document it, it didn't happen. And that holds true in EMS, but I don't feel like we've held it true to EMS. There's been somewhat of a lack of accountability with our documentation standards, and that needs to change. It's not going to change overnight. I know that some of you may have attitudes about documentation you don't understand, or you don't feel like it's as important maybe as it actually is. And I get that. I've been around enough that I know that not all of you are going to agree with me on this, but from a medical director standpoint, from a higher level healthcare system standpoint, your documentation is critical for patient care and patient safety. And this is just something that we need to come to terms with in EMS and put a higher priority on our efforts at documentation. And really, when we get into it, the narrative is the crucial part of the documentation. Another subtitle here in this article is that checkboxes collect data, but narratives paint pictures. Vital signs, fine. Line item interventions. We gave this medication, this dose, this route. We did this procedure, by this provider. That's fine. Here's your mechanism of injury, the car accident checkboxes, the cardiac arrest checkboxes. Fine. That's collecting data for computers to analyze, and a lot of that comes back to quality assurance. That's an easy way for us to evaluate the quality of care. But the narrative is what's going to paint the picture for the other healthcare providers and for the legal proceedings in the future to come back and refresh your memory of what happened and show the jury that you did a thorough assessment. You did explain the risks of not transporting somebody and the situation that you found them in. And then also from a quality assurance standpoint, we can go through and read those narratives and really understand why maybe some of the other stuff doesn't quite fit with what we expect, but you explained it and justified it in your narrative, and now it makes sense. There's a number of reasons why the narrative is insufficiently documented, and this author here mentions a lot of times medics don't do a good job of a complete, accurate, and thorough description of the patient's condition as they were found. We focus more on here's what we did and we brought to the hospital, and there's a lot of detail about how we moved the patient to the stretcher, what position they were transported in. And that's important too, but really we want to know, how did you find, what did they call for? How did you find them? What did you do for them? How did they respond to those treatments? What was the final outcome of the encounter of care that you had with that patient? And using objective data to support that. Looking around the room and documenting the condition of the house or the room, deformities, bruises, unusual things going on in the house, other people that were acting, very defensive or intervening in the care that seemed a little suspicious. Maybe that could come back later to help support a domestic abuse or human trafficking charge based on what you provide in your documentation. And also everybody on the crew is liable for the documentation of that patient encounter. So, if we really wanted to stick to the letter of that, you should have every single member of your crew review the documentation and agree that, yes, this is an accurate description of what we found, what we did, and everyone signs it. The reality is that doesn't happen. There's typically one person responsible for documentation, and you do take on that liability when you put your signature to that chart. So again, just keep that in mind. If somebody were to ask you, do you provide good patient care? How are you going to support that statement? Are you just going to give an opinion? Absolutely, we provide good patient care. It's much better when you can prove that you provide good patient care. And the way that we do that is through quality assurance based on your documentation. There's going to be more to come on that. We have some software that lets us analyze patient care reports and really do a lot of that quality assurance work. And I know some of you have been seeing that in some of your critical case reviews. But there's going to be more emphasis on that going forward in the future. So more to come on that too. One other thing that I should mention here is our February Regions EMS video update has a segment on performance metrics. We were able to interview the president of the National Association of EMS Physicians, Dr. Brent Myers, and he talked from a very high level government involvement legislation about what's going on with performance metrics in EMS specifically, and that goes back to documentation. If you don't document it, you didn't do it, and if you can't prove that you did it, there's going to be a point where you're not going to get paid for that work. If we're not proving that we're at least considering aspirin for every chest pain patient, whether they took it before we got there or not, you got to document that somehow. If we can't prove that, then the government's going to think that we don't know what we're doing and they're not going to pay us because they're only going to pay for high quality service. That already happens on the hospital side, on the clinic side. In most of healthcare, EMS is one of the last holdouts for what we call, pay for performance, value-based purchasing. There's a number of terms for it. But proving that the care you're providing is of a high enough quality to deserve being paid for. The only way we know that is through quality assurance based on your documentation. So I'd encourage you to check out our February video update. Watch the segment from Dr. Brent Myers, who explains very nicely what the current state of that is at a national level. And this is inevitable. There's a report that says that Medicare payments for EMS and ambulance transports increase faster than all other Medicare Part B payments over a 10-year period from 2002 to 2011, meaning that this is something the government is going to pay attention to because it's the highest expenditure for Medicare Part B, and it's growing faster than all other expenditures within Medicare. So there's going to be a point where they're going to pull those reins back and figure out, why are we paying for all of this when nobody's being required to prove anything that what they're doing is making a difference? We require that of the hospitals, like I said, but not of EMS. It's going to happen in most of your careers. So we need to be a part of the change and the solution and show the interventions that we believe are making a difference and prove that they're making a difference so that we don't have someone else from the government, most likely, telling us what we need to do in the future. If we can be part of that proposal with things that are relevant to us and to our patients, that's going to make our lives so much easier in the long run. So the second article talks about non-transports and documentation of a non-transport call. And a lot of times we think of these as low acuity calls, lift assist calls. A lot of them are maybe pediatric with a low-grade fever, a little cough. Third-party callers, welfare checks, medical alarms, where you go and you check on someone and then they end up signing. Those are actually probably the highest risk calls for you as an EMS provider and definitely for me as an EMS medical director. So your documentation actually should be significantly more thorough on a non-transport call than maybe it even would be on a transport call. One of the statements in here in this article, the title is Non-Transport PCR, Choose Either Thorough Documentation or Saving for a Lawyer. And maybe that's a little bit extreme. It's actually written by a lawyer, but the fact stands that non-transport calls have a high risk of liability associated with them. And when you transport a patient to the hospital, you also transport the liability associated with not transporting them, meaning that if that liability is on your shoulders and you transport the patient, you are now passing off that liability to the emergency department to decide what to do, and now that's off your shoulders. If you leave the patient where you found them and sign them, that liability stays with you. So now 3 days later, you're called back for a cardiac arrest or another fall, now with a broken hip or a head injury, and you are the crew that signed the patient, a few days or sometimes even a few hours prior. You can imagine what some lawyers might think about that as an opportunity to go after you or to go after the medical director or the agency for substandard care. And they're going to look at your documentation to see, did you really do a thorough exam? Was it really an informed decision by the patient to not go to the hospital? So it really comes back to your documentation. So again, the key take-home points here, non-transports are the most dangerous calls from a documentation standpoint. And I get it, not every patient wants to go to the ED. There's a lot of minor car accidents where you evaluate and not transport. That's not necessarily what we're talking about. I think a lot of this comes back to more of the lift assist calls and more of the older patients or the patients with significant chronic medical conditions or comorbidities that really have the potential to, on any given day, to tip one way or another as far as the spectrum of health. So there was a recent article, a research article published in April of 2017, looking at morbidity and mortality associated with lift assist calls. Morbidity meaning bad things happening, like further injuries, further deterioration in health. Mortality is death. And they looked at the death, ED visits, or hospital admissions within 2 weeks of a lift assist call. They looked at an agency that does over 40,000 transports a year. Identified all the lift assist calls they did in that year, and then did follow-up with all of those patients. They found fairly high rates of repeat encounters with healthcare within the 2 weeks following a lift assist call. And there's other data that supports this too, but for a lot of patients, a lift assist or a medical alarm is a sentinel event that signals some sort of a decline or an acute change in the patient's health. That really needs to be thoroughly evaluated. A lot of times it's an infection. Sometimes it might be a medication interaction. Sometimes it's just a progression of a chronic disease. But what they actually found, among other things, is that the patient's age was a significant predictor of a 2-week morbidity and mortality, which makes sense. Older patients have more chronic medical issues and are more at risk for this. But also, if you combine patient age with any single missing vital sign in the EMS PCR, that itself was a predictor of a repeat encounter. So, can you imagine, being called either, to answer, whether it's in court or quality assurance committee or patient safety committee, for a chart where you didn't document a full set of vitals, and 2 days later that patient got admitted to the hospital for a problem that maybe could have been prevented if you had gotten that other vital sign, assuming that it would have been abnormal or would have prompted you to do something else. But even if it had been normal, at least then it would have proved that you did a thorough assessment. You took a complete set of vital signs. It's one small piece to a big puzzle that we use to get the big picture of a patient's health and what's going on. One of the points here in this article on EMS1.com is know your audience for a non-transport PCR. Who's reading this report? Who is this report intended for? We mentioned that before. One of them is communication with other healthcare providers, so now the patient goes to their clinic. And unfortunately, EMS reports aren't fully integrated into healthcare in a lot of cases yet, especially with non-transports. Nobody has access to that report except you, unless you transport them to a hospital. So that's not terribly helpful for follow-up visits. Billing obviously is an issue, quality assurance from my standpoint. But then we're looking at the legal, defensibility when somebody says, yeah, the medics came out to my house 2 days ago, and now mom's been on the floor all night again. She fell again, and found to be septic. Maybe she had this infection before, and then they go after you, and these proceedings take some time, and now you're 2 years after the fact having to review this chart, and if you didn't document it, a couple things. One, you're not going to remember the call. And two, if you really don't document a thorough assessment and situation, there's a chance you might come off looking like an idiot. There are people trying to prove that you don't know what you're doing. And if your documentation is less than adequate, they're not going to have a very hard time doing that. It's much easier to defend a chart where it's very clear you took time to do a thorough assessment, explain a lot of things to the patient, and it's clearly documented exactly what you did outside of all the checkboxes. So I'm talking about the narrative documentation here. Also, poor grammar, unprofessional statements. Definitely don't use texting abbreviations. Subjective things. Don't try to use your patient care documentation to report on another family member who was there who was trying to assault you, and you're trying to get it in a legal record so that any further proceedings you can file. That's not the role of a patient care report. You're documenting patient care. There are some situational things that may be important, but this isn't a forum for you to communicate frustrations, to communicate failures of other healthcare providers or anything like that. We're focused on the patient in front of us at the time and what's best for that patient. One argument that we hear too is that you're too busy to do this, especially on these non-transport calls. You guys are trying to turn around and catch the next run so that you're not calling for mutual aid or an out-of-district company to come in and take that call for you. Again, this is part of patient care, and I can't emphasize that enough. You can't be too busy to document. You have to document. You have to do a good job. This is very important. So you need to decide, are you going to spend the time documenting, or as this author would say, or are you going to spend that time saving for a lawyer to defend yourself in the future? And I don't necessarily hold to that extreme opinion, but I think the point is well taken that documentation is important and deserves the time that you put into it. So just make sure that you're being very thorough with the assessments that you provide. So that's fine, but now how do you do this? What are some things? You learn this in medic school, and some of you that are documenting, are EMTs, and EMT courses really get not a lot of practice with documentation. I remember when I went through EMT training 15 years ago, and you get like 3 sample reports, and that was my training on report writing as an EMT. Woefully inadequate. So going now to Chris Kaiser from lifeunderthelights.com, he actually did an interview with a guy named Jamie Davis, who calls himself the Pod Medic. He's got a video cast and a podcast called the Medic Cast. You can go to mediccast.com. He's got hundreds of episodes. He's been doing this for a while. He goes to a lot of the national trade shows. But if you go to his website and you search for documentation and scroll through a couple pages and pull these out, he interviewed Chris Kaiser, and they went through these articles so you can get a little bit more of the back and forth dialogue, just getting into some of the meat of these articles if you're interested in diving a little bit deeper. So this is from Chris Kaiser. It's called 6 Tricks You Can Use Today to Improve Your EMS Narrative Report. None of these are magic bullets. You still have to put the time into it. You still have to practice, but there are a couple keys here. So one, understand that you made decisions on the call, or your crew made decisions on the call. Put the information that you used to make those decisions in your narrative. We used a stair chair to move the patient from the 2nd floor down to the 1st floor. Why did you use a stair chair? That was a decision. At one point, you decided that this patient is unable to walk down the stairs, or it would be inappropriate to ask the patient to walk down the stairs. Why? Put that in your narrative. You had an SVT patient, narrow complex tachycardia, that you did not give adenosine to, and you transported to the hospital. Why? Well, you know what? We saw this little delta wave. It looked maybe like Wolff-Parkinson-White. We weren't sure if it was regular or not, and we know that adenosine is contraindicated in Wolff-Parkinson-White. Great. Now you've just justified the decision that you made, rather than just a chart that shows an EKG and no adenosine and bunch of descriptions about the position of comfort that you transported the patient in. Number 2, remember that you're painting a picture with your words. And I have to do this too for my documentation in the ER. Nothing ever comes back to haunt you within the next few days. It's always months, years down the road when the patient complaints, or the lawsuits, or maybe it's not even a lawsuit against you, but it's legal proceedings surrounding that patient and something about that case. And since you were involved with that patient care, you're being called in to just provide your insight into the care that you provided. And so you need to paint a picture so that when you read that, it's very clear to anybody who reads it, including yourself, what the situation was when you were providing care for that patient, so you can easily refresh yourself later. A couple examples here. Patient's left lower leg was found to have a fracture below the knee. Fracture splinted in place with pillow splint and tape. Those are factual statements, but it doesn't really paint a picture. Now, if we take the same patient and compare it to the following narrative, assessment of patient's left lower leg showed a probable angulated fracture of the tibia fibula below the knee. Distal circulation was found to be slowed but present, with a capillary refill approximately 7 seconds with no palpable pedal pulses and colder skin distally. Unable to straighten fracture due to severe pain and resistance to manipulation. Fracture splinted in place with pillow splint and tape due to the above. So now you drop off this patient at the hospital, and let's say you had used the first very brief method of documenting. The hospital notes a patient with a cold, pulseless foot, and now they're going to challenge why you didn't straighten that leg. And you really have no way to defend yourself other than, well, because it's not in your documentation. The second picture definitely paints a much more vivid picture of the circumstances that the patient was found, the assessment, the thorough assessment, the treatment considerations, and some rationale for why you did what you did. So this gives me much more information as a medical director. Now I can go back and review that chart and reply to the trauma coordinator and say, the crew did consider that, but here's why they weren't able to do it. The patient was going to need procedural sedation in order to get that leg reduced and straightened out. Not something we can do in the field. It took an extra 12 seconds to write that extra narrative, but it would have saved you a lot of work in the end if anything comes up with this case. So the third tip, organize the order of information. A SOAP note is a common way of doing this. S stands for subjective, what the patient told you. O stands for objective, what you observe, physical exam findings, vital signs, visible things around the facility that you pick up the patient at. A is the assessment. You may not know the diagnosis, but the assessment is what you're going to base your treatment considerations off of. So, that might be rolled into the P, which is plan, and a lot of times we do that in the hospital too, assessment/plan. Here's what we think is going on, or here's things we've identified, and here's what we're going to do about it. Also, as part of that, an important piece that I don't often see is what's the response to those interventions. You have chest pain, you give nitro. What happens next? A repeat set of vital signs, a repeat pain score, pain decreased from a 7 to a 3. Or patient's pain continued to worsen. What did you do? You repeated an EKG, which now shows an evolving MI or STEMI. You gave more nitro. You repeated the vital signs every 5 minutes. So you manage the patient. It shows that you're reassessing, reevaluating, and documenting a response to treatment. Fourth tip here, take a few moments to plan what you're going to write. Just think about how you're going to phrase things briefly, run it by your partner, your crew, just to make sure everyone's on the same page and that what you're describing is actually accurate relative to the situation for that patient. Number 5, think about documentation during the call. As you're evaluating the patient, as you're looking around the residence, the facility, whatever it might be, just pick out those key things, and this just comes with experience. What's going to be important for me to document? What's important for me, information for me to pass off to the receiving facility, the receiving medical team? And then the last one, and Chris here, the author, basically says, do I really have to say it? Really? Still? And what he's referring to is we still have to remind people to use appropriate grammar, appropriate phrasing in your patient care reports. That's something that hopefully was dealt with in grade school and middle school, high school, but we still see a lot of reports that have poorly spelled words, bad grammar, no punctuation in some cases. You don't want this to look like, a poorly written 3rd grade book report on Stinky the Magic Dragon. You want this to be something that would stand up in front of a jury, worst case scenario, so it doesn't come across like you're an idiot because you can't even write a coherent sentence, but something that is professional, that reflects the professional that you are as an EMS professional, and that really communicates and paints a nice picture of the scenario, the situation, so that when you have to recall it down the road, or when other healthcare providers are looking at this to make treatment decisions for the patient, it's clear that a professional wrote this, they knew what they were doing, and it's very clear what happened in that situation. It's just a very brief overview, some high-level tips. Like I said, there's some resources. EMS1.com, you can search for documentation. LifeUnderTheLights.com has several articles, and there's a few more that I didn't touch on today. And then Jamie Davis, the PodMedic, Mediccast.com, you can search for documentation. He's got hundreds of episodes online from a variety of topics. And then also our February EMS video updates with the performance metrics and Dr. Brent Myers. We're going to be talking more about this in the future as we kind of ramp up some of our quality assurance programs and start looking at some documentation things and some key quality metrics, performance metrics over time, things like aspirin for chest pain, that kind of thing. So stay tuned. More to come on this, but just keep these resources in mind. Thanks for watching.